And there's a few things I want to wrap up about it before I go to upper respiratory infections. One of the things I wanted to wrap up about it is you have a wonderful handout in your packet that thoroughly covers some of the warning signs of asthma. It covers some of the triggers of asthma. And then if you turn, it talks about the medications. It's very important that you know these medications. If you look at the list, you'll see albuterol, you'll see Atrovent, you'll see the Pulmicort, you'll see language that says quick relief and control. If you go down a little bit further, you'll see using the inhalers with the spacer and the peak flow meter. Those things are huge. Remember, the peak flow meter is a way to predict an asthma attack. You know, people miss a lot of work in school because of asthma attacks. It would be nice, and it already is a way to do it, to be able to predict if my child is going to have an asthma attack today. Also, make sure that you teach the patient and the family that they do qualify for FMLA as long as where they're working has more than 50 employees and they've been there full time for a year already. They absolutely qualify for FMLA. So this is a big deal because it can save their job, because asthma attacks are, for the most part, something we can predict, but occasionally there's something that is just completely unpredictable. There is another handout in your packet that talks about the administration of medications, and it talks about spacers and MDIs and DPIs and nebulizers. Let me just say something about these meds, because we also use these meds with COPD. The spacer is a gadget that you attach to the actual inhaler, and it enhances the delivery of medication into the lungs. It helps with that delivery. Children always need a spacer. Most elderly need a spacer. People that are disabled or weak, they need a spacer. Maybe even your post-op patient could use a spacer to help deliver the drug to the lungs. The other thing is that there's something called a nebulizer. One of the issues with a patient with asthma or COPD is that they can never have their utilities cut off, especially the electric, because with the nebulizer, you can't use a nebulizer without electricity. And so if you cut the electricity off for a stupid bill that they owe, then you've just cut off their lifeline. So nurses and doctors fill out this paperwork all the time to prevent this person from getting their utilities shut off. Another thing to remember about the nebulizer, because we have moms and dads who have this precious child that just got diagnosed with asthma, and it pisses me off because they just give them this gadget and say, okay, give them a treatment anytime or whatever they need it, and they never really teach you about this treatment, how to do it, how to set it up. Two things you've got to remember to tell your patient, especially fathers who may not be as well versed in this crying that happens with this treatment as mom might be. Explain to father and mother that if the baby cries, fights, mad, pissed off, just acting crazy during this treatment, it actually is beneficial, because the more they cry, the more medicine they get in their system. So it's not as bad as they think it is. Parents don't want their children to cry, and they are pretty violently crying, so it's scary. So you tell them it's okay. If they're crying, they're getting more medicine. The other thing is make sure that they give this treatment until all the liquid medicine is gone from the ampule that they attached, okay? All the little liquid medicine must be gone before they're done, okay? Now, if you turn the pages, I want you to go to the page called Pneumonia, because now we're dealing more with respiratory infections. And so as we track through this lovely little list, I'm going to erase the things that we've covered. Now, pretty much I don't have to go on and on about pneumonia, but I do want to cover as much as I can that I think you should know. There are so many different types of pneumonia, but whatever kind of pneumonia it is, typically it's droplet precautions. You have something called hospital-acquired pneumonia, ventilator-acquired pneumonia, community-acquired pneumonia, and of course we have our post-op pneumonia as well. Okay, so it depends on how they got it, how bad it's going to be. But I will say this: For the typical community-acquired pneumonia, the number one way to prevent pneumonia was a flu shot. And that sounds crazy, because you would think I would say the number one way to prevent pneumonia is a pneumonia shot. No, the number one, a pneumonia vaccine, right? No, the number one way to prevent pneumonia is a flu vaccine. The reason for that is because the number one complication of the flu is pneumonia. And when you get to pneumonia, now you're getting more serious, and the number one complication of pneumonia is ARDS, or acute respiratory distress syndrome, and that's where we start talking about sepsis and death. So the patient can die from the flu or the pneumonia, but remember, most of this started with the flu, okay? Now, when you look at pneumonia, you can see all the different symptoms. My job is to teach you how to determine the pneumonia from a cold, from the flu, from strep, from allergies, from whatever. And so my job as I go through this chronic respiratory lecture is to give you the tips that tell you how does this differ from other stuff. With pneumonia, please quote me, it is a very painful, productive cough. Painful, productive cough that is going to give you purulent, and you got to know that word, it's going to give you purulent exudate. Now think about that. The cough hurts, it's very productive, and it's going to give you sputum or exudate that is a different color. Green, rust colored, blood tinge, yellow, something. Okay, so if you look in the little box underneath the guy's hands, it talks about the different colors. Now, if you look at the rest of the list, you see all of the different signs and symptoms. Pleuritic pain is that whole painful cough issue, but I want you to add a couple more things. Put crackles for your additional signs and symptoms. I want you to put that your chest x-ray, the chest x-ray will show infiltrates, or sometimes we say consolidation. Okay, so your chest x-ray will either show infiltrates or consolidation. When you listen to the lungs, they're going to be crackles, all right? So that's just, point blank what we know. Now, when you look at this handout, the most important thing, because people miss it all the time, they think that pneumonia is diagnosed by chest x-ray. No, it is not. It is diagnosed with a sputum culture. And sputum cultures are best done in the morning and taken physically to the lab. So sputum cultures is used for diagnosis of pneumonia. The care of the patient with pneumonia, other than making sure you implement droplet precautions, is going to include oxygen, humidifier, bronchodilators, IV antibiotics, positioning in semi-Fowler's position, rest, encouraging rest, have the patient cough and deep breathe. We might need to do some suctioning, some chest physiotherapy. We encourage the patient to do what we call huff coughing, H-U-F-F, huff coughing. This is going to enhance them being able to have their cough be productive. That's called enhancing expectoration, huff coughing, encouraging the patient to literally expectorate. Okay. The patient could benefit from an incentive spirometer. They will usually get serial x-rays, like repeated x-rays, to see how it's going, how things are moving along here. If you turn a couple pages, you'll see the different types of pneumonia and the different treatments. Every now and then a doctor might prescribe steroids, especially, and I want you to write that under treatment. They may want steroids, especially for COVID pneumonia. COVID pneumonia is going to require steroids and remdesivir, minimally, okay? All right, now, so if you keep on going and you turn to core measures, you will literally see where it talks about the vaccine, and it says influenza vaccine status. Please put a star by that, because the best way to prevent pneumonia is the flu vaccine. You'll also see the sputum culture that we have here, just to make sure that you write across the page. The only way to diagnose TB and pneumonia is a sputum culture. The next page, you'll see like nasal cannula, different ways to deliver oxygen. I want to say a few things about the nasal cannula, and here in your pink procedures packet is a very big explanation about oxygen delivery systems. Let me just remind you of a couple things you probably already know but may have forgotten. Room air. Room air equals 21% oxygen. So if you look at this nasal cannula, you will see that it's not much higher. Look at that. It says 1 liter, 24%. 3 liters, 32%. It's just not that high. And don't forget, please write it down, that the limit for your nasal cannula is actually 6 liters. And so if your patient needs more than 6 liters, they're going to need another mask, a different kind of oxygen delivery system. And if you turn the page, maybe it's a simple oxygen mask, and you can see that at 6 liters, that's 40%. If you put it all the way up, it's about 65%. It's still not 100. And so you'll see at the very bottom of this page, it repeats the nasal cannula. What I did instead is I put non-rebreather mask, because I didn't have a picture for a non-rebreather mask in this section, and I really want you to know what that is. The non-rebreather mask, and you really got to listen to me, the non-rebreather mask is going to go over the patient's face, but you have to, quote me, big letters, put stripper glitter all over it, you have to inflate that mask first. If you don't inflate it first, this is going to be crazy. Okay, so you inflate this mask first before you put it on the patient. You put it on the patient's face. The next thing you got to remember about this non-rebreather mask is that it needs to be at 10 to 15 liters. Because anytime I'm using a non-rebreather mask, which is 100% O2, I'm using it because of respiratory distress. And if you are truly in respiratory distress, I probably need to crank it up. Okay, so that is your pneumonia and your oxygen delivery. Now, the next thing we're going to talk about is a cold and a flu, other upper respiratory conditions. When it comes to the cold or the flu, you do have a handout. It says, is it a cold or the flu? I'm not going to go on and on and on about this because you already know what this is. But what I do for you in terms of the flu, and this is, by the way, droplet precautions. What I want you to know about the flu is that the nurse can tell it's the flu versus something else if she remembers her 7 symptoms. So let me show you what I have. Headache is first at number 1. Then you have body aches and pains. Okay, now let me stop right there. So headache is first, it's number 1, it's always there, it's guaranteed. Just like with COVID, it is number 1, right? But when I say body aches and pains, which is 1, 2, 3 of the 7, I literally mean you feel like a Mack truck has run over you, somebody has stomped you, and then came by and shot you. Okay, that's how much pain we're talking. It's the same kind of pain that you might have had with the second COVID vaccine like I did. It was horrible. That's flu-like symptoms, right? So this is 3 so far. Let's keep going. So we got 1, 2, 3. Let's do 4. Fever and chills. That's 5. The fever may be low grade, 102 or less, okay? It may be a little bit low grade, but the chills is noteworthy because when a patient has chills, they're getting into an infection. Don't forget, the only people on your test that are allowed to have chills are people who just got out of the operating room or someone who just had a baby. If they're not one of those people, they have no business having chills, your job is to check their temp because they're probably getting a fever. Okay? Now we're going to put some more words on the board. 6, anorexia, and 7, fatigue. Okay? What does it mean? Loss of appetite, and now you're tired. So they go together as well. So headache, body aches and pains, fever and chills, anorexia, and fatigue. If you don't have all of these, the minimal needed for it to be the flu is these. You could add to this. You could add a cold, you could add a cough, you could add a sore throat. You don't need any of those for it to be the flu, but you need all of these for it to be the flu. So now you know how to tell pneumonia from the flu. Now let's talk about a cold. You have the same page, and in order for you to remember this whole business about a cold, just remember these fancy words, Adenovirus, which is what causes a cold, and rhinitis, which means your nose is runny, okay? When it comes to a cold, you don't have the fever. You absolutely do not have the fever. You do have the runny nose. You may even have a bit of a headache or something. It's rare to have that headache that you have with the flu. It's rare to have the headache that you get with COVID. You may have a sore throat. You may have a runny nose. You may be sneezing and coughing, but you just don't have the drama that you have when it comes to the flu. Now, because the flu can become pneumonia, it is critical for you to remember that any patient with the flu that is high risk needs to come in for Tamiflu within the first 48 hours of symptoms. Tamiflu is an antiviral, and the way you're going to know that, like I always teach you, is the medication ends in VIR. The medication will end in VIR. This is for your high-risk patients. Who am I talking about? Sickle cell, diabetics, COPD, CHF, kidney failure, anybody with a history of cancer, MS, lupus, Guillain-Barré, ALS. Those patients need to get pregnant women. They need Tamiflu as fast as possible so that we can make sure that this flu doesn't turn into pneumonia. Now let me just say something really quickly about a flu shot because people are very confused. When you get a flu shot, it doesn't mean you're not going to get the flu. Nope, doesn't mean that. Sorry, it does not mean that. What it means is that your flu will not turn into the deadly pneumonia. And some people don't get the flu, but others do. But when they do, it's a mild version of the flu so that we don't have the complications like pneumonia and subsequent sepsis and death. Lots of people still die from the flu. But you know, you heard people running around the state, this country, saying COVID is just like the flu. Well, that was the stupidest thing you ever heard. Because if we look at the number of deaths that occur from the flu every year, we're somewhere around 30 to 50,000. 2 years ago, we had a big high of 80,000. COVID is now, at this point, we'll just call out the date, I think it's February 17th, we're at damn near 500,000 dead. It has surpassed every cause of death in our country. Heart attacks, diabetes, whatever, cancer. It's at 500,000 deaths. So much for the bullshit that it's just like the flu. Yeah, not so much, okay? All right, so that's that. Now, when we come back, we're going to talk about mono and strep throat and some of the other things that move down a little bit and show up a little differently, okay? So, talk to you later.